Okay, Debbie, here we have your models, and what we're going to do is take a look at what would be involved quantitatively. How much tooth structure would I need to remove from your teeth to get them to fit together better, okay? And maybe want to take away some teeth and add on to some. This is literally how I do it. I don't want to experiment. I don't want to find out in your mouth. I want to know what's going to happen before we do it.
Okay.
And this is what we want to find out.
Okay.
So first of all, we're going to start off by marking, and not surprisingly, we're going to find that first point of contact is right where we expected on the back end of numbers 31 and number 2. And I go in and even though I don't use this kind of an instrument in your mouth, I'm going to go in just as if we were doing that. And I can use either by the way, I can use either a handpiece while I'm doing this, or I can use, again, a hand instrument. The idea we want to get across here is we'd like to get a sense, again, of number 1, how much tooth structure do I need to take away from which teeth, and what's going to be the relationship of the front teeth. The front teeth, how are they going to couple, how are they going to mesh when I get the back teeth to fit? And that's a very, very important thing we're trying to find out here. So I'll just keep looking away at it here. Now, more typically when I do this, I will do it with a handpiece, but I'm showing you. And we see we're starting to pick up, as you can see, several more teeth starting to come into contact, okay? And we really haven't done anything very much. I mean, we've gone at the maximum depth, maybe an 1/8 of a millimeter, if anywhere, very minimal. But as you can see, we're getting a lot more teeth coming into contact here. And as I'm adjusting these for the benefit of those that are watching, always want to adjust on inclines. What we find is as a result of our equilibration, we'd like to have not only a coordination between the muscles and the joints, but we would like for those contacts to be directed such as to direct the forces as axial as possible. And what's interesting, we find so very commonly when I go in and I'm eliminating only inclined contacts, essentially trying to move those contacts up onto the cusp tips and into the fosses. When we do that, it's amazing how everything seems to just fit together. And so I'm not really so much shortening your teeth, Debbie, as I really am reshaping the teeth. Okay, I am removing tooth structure, but I'm not like bringing them down. I'm just recontouring. Those contours, those we call inclines between the pits of the teeth and the tips of the teeth, we're reshaping them, making them maybe a little less bulbous. Okay? And that's literally what we are doing. And along here, we're getting more and more teeth coming in together. And you can see too, the contacts are trying to be more centered into the fosses and less on the inclines. And we'll go on. Looks like we've got a contact already of one of our eye teeth. Very typically, when I'm doing this for the benefit of those watching, I will equilibrate until I have all the posterior teeth in contact and one upper canine. And again, we'll go over someone specifically later on, the specific goals of the equilibration, but that's typically where I will choose to stop. And then, if necessary, additively restore to the additional canine. Again, the idea is we'd like to get a coupling as ideal as possible with a very minimal amount of tooth structure being removed. And oftentimes we'll find that we'll have all the back teeth in contact, well, one canine in contact, which we absolutely want. The one canine will still be, maybe 1/4 millimeter, 1/2 millimeter out of contact. Well, I have the choice at that point in time to either take everything else down to bring that one tooth into contact, or to add on to that one tooth. And very, very typically, most commonly, we will choose to add on to that tooth. And I'll use, for the benefit of those that are listening here, a nice hybrid composite. And it's held up very, very, very well. It's a very simple procedure and we may need that on you also, okay? So as we are here now, let's get our shim paper here. Still don't have contact there. Still looks like we're heavy on this side. Yeah. But now we've got contact basically almost on that entire right side.
And we need to keep going until we get contact on both sides?
Yeah, I'd like to. Again, that becomes that's a good question, because how far do we go? The point is very typically everything will tend to seem to come in at the same time, but we oftentimes get to the point where we say, all right, we've got a couple of teeth or a few teeth. Are we comfortable at continuing to take away? Because we can literally equilibrate probably virtually anybody in, but we certainly don't want to do anything to the point of being mutilated, okay? So and that's what we're looking at with you. And sometimes that final decision isn't made until we're in the actual clinical environment where we're actually doing it to you.
Okay.
And we're saying, you know, are you having any sensitivity? Are there any issues like that? And we, at some point in time, if we understand that our goal is to coordinate and to have an equal intensity contact of all the teeth when the jaws are in their physiologic position, again, when do we stop taking away and when do we choose to add on, okay? And that's an individual situation. And that's a decision that's made really chair side. This gives me an idea of what I can tell you, well, you may or may not need to, okay? And even though we may suspect that or suspect one of those answers, really that final determination really made on you clinically, okay? All right, so as you can see though, I think we are getting some contact here between these teeth here. Where's my shim here? There we go. Yeah, you got a little hold there, a little hold there. It's still a little loose there. Hold there, loose there. Looks like my heavy contact's right here now. Now, later on, in our next session, if this is the way you want to do, you know, we'll actually be doing this chair side and then we'll be able to see this actually being done. It's actually in some ways harder to do in a model than it is in the mouth. And again, I'm not looking for a perfect resolution here. I'm really trying to get a sense for myself and for the patient, quantitatively and qualitatively, what I need to do and what I can do. We've got everything just about in contact here. And from what I can see here, Debbie, the reality is that we're going to probably be able to get down to with virtually just with the reductive type of reshaping and get all the back teeth into contact. Okay. I don't know that any of the back teeth would have to be reduced so much as to require us to add on. If we find that in your mouth though, that you know we're going and I'm seeing that we're getting some dentin exposed or if there's a sensitivity issue, we may choose to stop at that point in time. And whatever teeth still aren't in contact, very conservatively, very conservatively, with some composite bonding, add on to them. You know, we could do it. Obviously, we could add on to those teeth with crowns or much more extensive and expensive restorations, and oftentimes that's necessary. In your situation, because you have minimal existing restorations in your mouth, you don't have a lot of fillings and you don't have a lot of breakdown in your mouth. We would like to do that as non-invasively as possible. Okay. So we see here. And by no means is this completed yet, but we have a very nice coupling of everything on the right-hand side. We have a very nice coupling of all the posterior. I have my eye tooth here still being a little bit out of contact. I'm not holding here yet. And again, I've got contact or holding on all the posterior teeth here. I have no contact of any of the anterior teeth, which is not a problem, because we're going to probably be restoring them. And in reality, even if you weren't restoring them, we don't want them in contact, all right? So as I see it, most likely, if you were to choose to do something irreversible, okay, if you were to choose to do some kind of a permanent treatment, I would do, as I've said here, probably a very conservative amount of reductive reshaping and probably necessitating a little bit of additive reshaping to this eye tooth. Okay. Now, if you are in fact going to go ahead and proceed with porcelain veneers on these upper anterior teeth, as we talked about earlier, that change or that correction could be made in those veneers. Also, if you had an issue with the alignment of the teeth, certainly we could initiate or bring in some orthodontic treatment into this case, all right? You've indicated that that's really not something that you were looking for, and I'm very comfortable that we can establish a very stable occlusion without having to require any kind of orthodontic treatment. Restoratively, I think we can, if you choose to do anything at all, we can aesthetically make these look something that would be very acceptable to you, and we can establish a type of anterior guidance that will be acceptable. In fact, go ahead.
If I go in and restore without doing the reshaping and what are the chances that those restorations are just going to be damaged again from my bruxing? Probably
good
pretty
question.
Good.
We don't know. I mean, honestly, I don't know. Again, and we can keep you in a night guard. I mean, you know, we can keep you in a night guard, and I'm very confident that if you wear that night guard faithfully, which you have, and you've had one in the past, you stopped wearing it. My experiences with night guards is people don't always wear them. Okay, and although this is not going to make you bulletproof, and you may still need to require to wear a night guard, but it's going to be more forgiving. I think it's going to minimize the chances of you causing any damage. This is essentially something that, as I look forward to you, as I would adjust or describe what it would do for you, is something that's really going to kind of stack the cards in your favor. Okay, there's a number of issues going on here. I don't know how many of the factors of the problems that are going on in your mouth we have direct control over. This is one area that we can express or can do something that I think will minimize, potential problems for you.
Okay.
And if we look, by the way, I should have shown you here too. If you go into the anterior guidance, as you can see, even though those canines aren't very high, we're getting still a very nice cuspid disclusion here, okay? As flat as you are, as flat as the back teeth are, as flat as the front teeth are, you really don't need to have much lengthening and much change in your front teeth. And you can still have a nice, as we talked earlier about your back teeth not wanting to touch when you slide from side to side. And we can accomplish that with very minimal, if any, additional restorative treatment.
Okay.
But since you're going to be doing that, again, we have a lot of freedom then, a lot more liberty as to what we can do as far as, yes. So again, I think if I were to look at this as something, if you choose to do, I would look at this part of the treatment as being a part of an overall package, okay?
Okay.
To state your concerns from the beginning, or your goals from the beginning, you wanted to have, number one, hopefully some control or remission of your clenching and grinding.
Correct.
Maybe about a 50-60% chance that we might be able to accomplish that, okay?
Okay.
Secondly, you wanted your front teeth to look better, all right? I'm very confident that we can do that, and I feel that as a result of doing this, we're going to, minimize the chances of you having problems with those teeth also in the future.
Okay.
And so it's really up to you. If you want to go this way, we'll go ahead and schedule, and we can do that equilibration. And again, that would be our next visit. Now, if you want to do that, I should note too that what we will want to do is between now and I'm going to want you to be in that appliance you are in now for at least another couple of weeks.
Okay.
And what I'm going to do today, before we do that equilibration, I'm going to actually reduce that little island behind your upper front teeth. I'm going to reduce that until one of those teeth is touching again. And ideally, it's going to be touching that same spot again.
Okay.
So I'm going to want to have you basically contacting on that front point and on that last tooth, and have you go for a couple weeks at that point.
Okay.
If you're still very comfortable, I'm very comfortable going in doing the equilibration if you think that that's something that's worth the time and the energy and the money to do it, and what it's going to do for you.
Very good.
Okay?
Very good.
Okay.